So the next speaker is Professor Monica Slavin again, if I could invite her back up to the stage. She's going to extend on her previous presentation, this time, to talk about challenges with optimising antimicrobial treatment in immunocompromised patients.
Thanks, Jason. So a lot of what I'm going to talk about has been covered in some of the earlier talks, but I guess I'm going to put it in the perspective from a clinical perspective and how it impacts on how we treat patients. And I'm going to focus largely on cancer patients, as that's where I work. And I've got a picture here of the new Peter MacCallum, or the new Victorian Comprehensive Cancer Centre, which has just been opened in Parkville in Melbourne and really brings together a whole sort of area of expertise in treating cancer and haematologic malignancies, and is actually quite a lovely building if anyone's in Melbourne to come and have a look at it. So I'm going to talk about some considerations and touch on a few of these in my talk. Sepsis is common in the immunocompromised, and I'll show you some of our data looking at numbers of patients with sepsis. Of course, as Jeff's already told us, drug dosing is derived from healthy volunteers. What do these doses of antibiotics really mean to a patient with febrile neutropenia, for example? And treatment's usually empiric and with a one-size-fits-all dose. One thing about oncologists and haematologists is they're very good at following protocols. And there are protocols for antibiotics in all the haematology-oncology units, and they don't vary doses. The doses are all the standard doses. And the question is this right? Is this correct? Many of our patients are on organ support. Antimicrobial experienced patients, these are patients who are having treatment over many years sometimes, just like the CF patients, and have multiple experiences with antibiotics. And of course, labels of antibiotic allergies become more and more common the more antibiotics you've received. This is an issue sometimes in treating patients when you're left with a patient who's listed as being allergic to just about every antibiotic you might think about giving them. Multiple drug-drug interactions, colonisation with resistant organisms, also are probably a function of the number of antibiotic treatment courses and the amount of antibiotic exposure that these patients have had. And we are seeing increasing prevalence of VRE, of resistant gram-negatives amongst these highly antibiotic-experienced patients. And I'll talk about that briefly. So what about fever and neutropenia? Just to set the scene, some data from Victoria, and it's quite old data from 2008, but just in the state of Victoria, there were 1,564 haematology patients admitted with individual episodes of fever and neutropenia, costing at that time quite a lot of money to treat. And when we look at it, about 12% of those patients ended up in intensive care. And I'll show you some more recent data showing that it's probably about 25% of those patients now. Also, 1,000 admissions in the state of Victoria for febrile neutropenia in solid cancer patients. So we're looking at 2,500 admissions a year, and yet we really don't know a lot about giving antibiotics to these patients. So I guess this just sets the scene of what a common admission this is for a centre that's treating cancer patients. And when we look at some of our, an audit we recently did in 2014, looking at who are these patients, some of their characteristics, you can see the BMI really is interesting in that probably around 20% of patients are outside the normal BMI range, above the normal BMI. And this is pretty normal, I guess, across society in general. But it does raise the point about why do we have such rigid protocols about dosing? Should we be adjusting for the increasing number of patients who are obese or outside the normal BMI? Charlson Comorbidity Index, another way of quantifying how many comorbidities a patient has. You can see that the average was 5. So these patients are actually quite complex and have multiple other medical conditions. So we know about dosing in obese patients. We know that we don't know, basically, of how we should do this. We know that there are a lot of alterations in how obese patients handle antibiotics, and there are some data out there saying that we should be increasing the dosage of several classes of antibiotics for obese patients. But this hasn't really been factored into our day-to-day practice as yet. And one of the challenges is really when we look at how do we adjust for increased body weight. There are multiple formulae that we can use to adjust for body weight. We can look at adjusted body weight, we can look at total body weight, we can look at ideal body weight. And it's really not clear for a number of antibiotics which of these formulae we should use to adjust our dosing. And this is a study that was done looking at voriconazole in obesity, showing range of levels, quite a small study, but looking at normal body weight, obese body weight. If you dose on actual body weight, you'll be seeing your average levels around 6 or above, which of course, as we know for voriconazole, puts you into the area of increased risk for toxicity, both hepatotoxicity and neurotoxicity. So this is not obviously the right way to dose. Do we dose on ideal body weight? Do we dose on adjusted body weight? And from this small study, we can't tell. But I think it points out that we do need further research on how do we adjust our doses for these group of patients. What else do we find out about our patients? Those being treated for neutropenia and febrile neutropenia. This was an audit of people who had had chemotherapy in the previous 30 days. Not all of them were neutropenic. You can see here some of them were neutropenic, some of them were not neutropenic at the time they presented. But interestingly, average heart rate increased in these patients, range of heart rates, and you can see that also hypotension, although not common, was definitely a problem in a percentage of these patients at presentation. So again, raising the question, as we've heard about, do these type of circulatory changes mean that the patients are going to be handling antibiotics differently? We just don't know. And this is really just at presentation when we're deciding on their initial dose, not after they've been septic for several hours and become sicker. The other thing that we looked at was the time to giving them their antibiotics. Obviously, that's been shown in the critical care arena to be very important, to give prompt antibiotic therapy. And we developed a sepsis pathway in our hospital for all patients. And actually, we were quite good at getting patients onto antibiotics within a short space of time, 40 minutes, if they were on this septic pathway. But if they weren't, not so good. And you can see that one of the reasons we developed this sepsis pathway, was because when we audited, we found that patients sometimes were not getting onto appropriate antibiotics for 24 hours. And this is in a cancer hospital where you think that people would have a heightened awareness for prompt management of sepsis. So I think one of the other problems that we've still got to tackle is not only what dose do we give, but what processes do we have in place to make sure that the patients are getting their antibiotics in a timely fashion. This is just our protocol. I don't want you to look at it. It's the sepsis pathway. It's got the antibiotic doses on it. And I really just put it up to show you that we're wedded to our standard doses, our pip-tazo, 4.5 grams 6 hourly, our cefepime 2 grams, and that usually is given 8 hourly, and our Cipro for those that are allergic to penicillin. So I think the question really remains, is this right? We've got this in our medical records, this is what everyone follows, but are we dosing correctly? Is our dosing interval correct? And I'm really looking forward to the information that's going to come from this CRE, because I think by the end of the 5 years, we'll be able to answer this question. At the moment, we just don't know. Renal impairment, another very common problem for patients with febrile neutropenia. And we did an audit in our hospital looking at patients who came in with normal creatinine or creatinine less than 130 and who were started on vancomycin and who achieved therapeutic levels. Actually, many of the patients didn't achieve therapeutic levels and were only on it for 24, 48 hours before stopping. So we didn't include those patients, but we included those who reached therapeutic levels. And we saw that 26% of all patients who were on vancomycin got renal impairment. And we saw that in the over 60 age group, it was 40%. So renal function is a very big player in our patients, and something that we're probably not really taking that much notice of. And equally, I think we've seen this slide already from Andrew Udy, and this is his work showing the rapid clearance of piperacillin tazobactam in those patients that have increased glomerular filtration rates. And I think that equally, we've started to look at how many of our patients have renal impairment, but we haven't really looked at how many of our patients have enhanced clearance and enhanced creatinine clearance. And although this work has been done in the critical care arena, it hasn't been done in patients with febrile neutropenia. And I think it would be very interesting to look at this group of patients because we may find similar, particularly in those young patients that we see who we can never achieve therapeutic vancomycin levels in because they clear it so quickly, and there is quite a number of those in the cancer treatment area. Also, as Jeff's pointed out very elegantly to us, we don't really know how to adjust for various types of renal replacement therapy, which many of our patients are receiving whilst they're septic. What about the outcome of sepsis, and why am I so concerned about dosing appropriately? Well, in our audit, we saw that of all the neutropenic febrile patients, a third of them had a bacteremia, and a microbiological proven infection was found in nearly half. So these patients, although they're presenting with febrile neutropenia, most of them actually do have an infection that we do seriously need to treat. It's not just a side effect of the chemo or a cytokine storm in relation to having a tumour breakdown. It's actually most often infection. And even in the non-neutropenic patients, bacteremia was quite common at 15% and a microbiologically proven infection in nearly a third. So currently, how are we doing? You can see the mortality rates from our recent audit of patients with febrile neutropenia and febrile without neutropenia. Neutropenic patients, 30-day mortality, nearly 16%. So really, for patients that are having curative treatment of chemotherapy, it's really not a very good outcome. And I think there's definite room for improvement. You can see the length of stay for these episodes of 15 days, and you can see that the ICU admission now is around nearly 20%. So these are a group of patients who definitely need further attention to how we dose their antibiotics. What about antibiotic allergy labels? And this is a really fascinating area, and Jason Trubiano is doing a PhD in this area based at the Austin and Peter MacCallum Cancer Centre. Lindsay Grayson is also one of his supervisors. And when he looked at our Peter MacCallum patients, he saw that 23% of them at any one time, inpatients, had an antibiotic allergy label. And that actually this conferred a poorer prognosis. If you had an antibiotic allergy label, you actually did worse in terms of you used more antibiotics, you actually used more fluoroquinolones, you had longer courses of antibiotics, you got readmitted more often, and of course you had less concordance with prescribing guidelines. And so Jason, as part of his PhD, is actually investigating these allergies in a lot more detail and really finding that approximately 90% of them can be removed with a good history and some simple testing to see if the patient is truly allergic. So as you probably know from ill patients who are receiving multiple antibiotics and multiple other drugs, it's very hard to pin down whether a patient truly does have an allergy, and a lot of things get labelled as an allergy that actually are not. So I think this is an actual area of work to improve our prescribing of antibiotics in this group of patients. And this was one of our patients, and she consented to have an article written about her in the Sydney Morning Herald and The Age relating to what it meant to have sepsis and ongoing infection. And this was a very brave lady who had multiple myeloma for 15 years and only died last year after being diagnosed in 2000. And I think she points out a lot of the issues around antibiotic experienced patients. And for her, she got her resistant organism right at the start. She needed to have rods put into her spine because of pathological fractures in her spine and pelvis, and got MRSA infection at that time. And so it was an ongoing saga for this lady of having a long-term antibiotic therapy. And she said, you can find her interview online, and she says some very sort of scary things about what it's like to experience recurrent sepsis and ongoing infection with sinuses from her spine. But I think, this is the face of some of the antibiotic resistance that we're seeing in patients who are actually surviving their cancers, being well treated for their cancers, but then run into problems with multi-resistant organisms and actually run out of treatment options. This lady along the way had pristinamycin and fosfomycin and various old drugs being recycled because her infections became more and more resistant over time. So I think this type of patient who's had multiple courses and who's surviving with cancer and with infection is going to be something that we're seeing more of. The other issue that's reared its head recently for us was a multi-resistant outbreak of VAN-A, VRE, believe it or not, in our haematology unit. We've had a very long-term sort of endemic focus of VAN-B VRE, and we've all become rather kind of inured to VRE, and yes, everyone's colonised with VRE, and we give them antibiotics in their febrile neutropenia to target VAN-B VRE, but we suddenly discovered we were seeing VAN-A VRE, not only VAN-A VRE, but VAN-A VRE, which was not susceptible to daptomycin. And this was a real problem because it only leaves one antibiotic, and that's linezolid, which is not an easy drug to give to people having treatment for acute myeloid leukemia because of potential bone marrow toxicities. So this is sort of the emerging kind of face of dealing with antibiotic use in the immunocompromised arena. So I guess in summary, I've tried to show you a little bit as a clinician about how we really do require careful optimisation in the immune-compromised patient. But at the moment, we're really wedded to a one-size-fits-all approach in terms of dosing and dose intervals. There are many factors in this group that make selecting the correct dose difficult, and it's actually a dynamic challenge because the patients can deteriorate rapidly and their parameters can change rapidly. And we don't really have good dose information in this group, despite the frequency of how often we use antibiotics in this group. We are seeing emerging antimicrobial resistance, and I think research such as this CRE is actually a matter of urgency for these patients. So I'll stop there.
Just a question of sort of size. You showed that 30% of the neutropenic patients who febrile had bacteremia.
Yeah.
How many patients was that? Was that like 50 or 200?
Yeah.
How big is your place?
Yeah.
When we think about doing Australian-wide studies, sample size and feasibility.
Yeah, so I think over a year we probably have in our one centre at the Peter MacCallum Cancer Centre 200 episodes of febrile neutropenia. But if you wed that in across the whole Victorian Comprehensive Cancer Centre, where you're looking at the stem cell transplants and acute leukemias as well, who are based at the Royal Melbourne, it'll be another 200 basically. So 400 a year in one centre. And it is a big problem, and it actually shocks me that we haven't been able to study it better, I think.